it's almost August. So welcome to everybody to our Idea August presentation. Um, so I ran into Andy. Whenever I travel abroad, Andy shows up somehow. I don't know why. So I ran into him back in when we were at an autism tech conference in Doha, Qatar. And then I ran into INSAR and we're like, hey, would you be interested in presenting for IDEA? Andy's one of those guys who like everyone I think has heard his name, but like he's also this thing up there in the cloud that no one like really knows what he does or how he does it. So he's been around for a long time. I think he joined Autism Speaks back in 2006, I think it is. So 20 years, almost 20 years ago. So he's been around and seen the entire evolution of that entity for such a long time. Again, the reason I wanted Andy to speak is his breadth of experience and just who he knows and what he has seen is always valuable to our field. He's now the chief science officer for Autism Speaks. I think he does like grant making. He's in charge of, are you still in charge of the missing data stuff and the Autism Care Network, all that stuff? So be nice to him. He's in charge of lots of things. So what I love about him too, he has a PhD in molecular cell biology. Is that right? So, wow. But Andy's one of those guys that, like, even though, like, I always viewed him up on this huge pedestal, and then you go talk to him, and he literally is one of the nicest people you'll ever meet. He's just so approachable and so kind. He's just a genuine human being. So, I was really pleased when Andy agreed to speak for us for the idea group. So, Andy, with that, I will turn my camera off so as not to be distracted, and it's all yours. I'll pipe in around 10 till the hour, just so you know
Okay,
that we're running up against some time, okay?
that's great. Thank you, Steve. And thank you, Steve, again, and the organizer for giving me this opportunity to talk a little bit about some ideas that's been percolating out in Speaks. So as Steve said, I've been in the community for over 20 years now. Majority has been at Autism Speaks. So when I talk to people about my tenure, the often question is like, what is wrong with you, right? And but I think the reason I've stuck with the community and especially Autism Speaks because I feel like I can still make a difference on a daily basis. And so I really had the privilege, really relatively charmed career, I would say, to be involved with some of the major efforts in the research community. And I always see myself more as a facilitator and a salesperson, right? The idea of trying to sell ideas, trying to get people interested and engaged in doing research is kind of my role. So about 3 years ago, Autumn Speaks undertook a strategic planning process because there was a recognition that the autism community has changed a lot in the past decade and even the past 5 years, and that we really wanted to rethink about what are the gaps and how can we make our modest investment in the grand scheme of things more impactful, right? And so one of the things that we started thinking about is aging and autism. And it feels like that there's really a positive knowledge in this area. Um, and what I'd like to do in this presentation, really just talk a little about and these are, as I said to Steve before, in agreeing to do this presentation, is that, there's really a paucity of knowledge in this area, right? And there are many reasons for that. I mean, if you think about it, autism only identified, a little over 80 years ago, first described a little 80 years ago. And in terms of active autism research as a discipline, it's been about a quarter of a century, maybe at the most at this point. So really haven't had that much time to really investigate this issue. Um, but I'd like to talk a little about what do we know about autism and aging, and then more specifically, what do we know about autism and dementia, and what are the implication and opportunity of a better understanding of these issues for research and care. So like I said, since it's been almost 80 years, over 80 years now since Connor first described autism. And I would say that, I think consensus is that there's a striking absence of knowledge about autism in older age, right? I mean, I think it feels like, at the time I've been in the community, there's been an evolution in terms of our understanding about autism. And I think even to this day, I mean, to this day, if you take everything we know about autism and put it on the table, we see a much higher concentration of knowledge and understanding and insight in early childhood. But as we move up the age range, we know less and less. And I will argue that by the time you get to older age, we know almost nothing, right, about what their needs are and how to better support them and help them maintain a well-being and quality of life. Uh, and of course, some of Connor's first patients have now have aged as well. And I know if you haven't seen a movie that came out a couple years ago by uh, Donovan Zucker, they wrote a book, Autumn First Child, which is about Connor's first case number one, Donald T. And it's about his life, right? He recently passed away, I think, last year, but it's really a beautiful film, and it really kind of give you a different perspective about autism, at least a more lifespan perspective. So what we do know is that, from report in recent years, small scale study, but like this one from Lisa Krohn at Kaiser Permanente, then we do know that, in autistic adults, we do see an increase, a higher prevalence for just about every NCDs, right? Gastrointestinal disorder, hypertension, diabetes, obesity, sleep disorder, you name it. And of course, this finding has been replicated by Brittany Han et al., as well as others. And I've asked about in 2022, 3 years ago now, when we first started exploring this issue, we held what we call a thought leadership conference. For 2 days, we invited autistic people, their caregivers, representative of CDC, NIH, the research community, people who are doing geriatric research in general to share, their perspective insight, to really get a sense in terms of what is happening in our community relative to the aging issue. And what we learn is of course not encouraging. And I mean, there's a host of issue in the community at this point. And I think to sum it up, I think the general impression I was left with after a 2 day conversation is that, you know, autism is so adult medicine, right? Autism is invisible to adult medicine largely, and this is very similar to pediatrics 20 years ago when I first got into the community. Very little expertise, very low understanding, almost no training at all, and so as a result, the quality care that's being delivered to the patient is often subpar and doesn't really uh, you know, goes toward, significantly towards maintaining a sense of well-being and quality of life. And other things that we've learned at this gathering and from Joe Piven at UNC and other. This is a publication from Marsha Malik, who's one of the few researchers who have done some longitudinal research in autism. And this was striking to us. So on the right-hand side, you see the, activity living skills, basically. On the right-hand side, you see uh, daily living skill for Down syndrome, people with Down syndrome over time. And you see that their skill is not only maintained, but also slightly improved over time. And this is obviously very, very understandable. But but when you look at autism, it's actually very alarming. What you see is that there seems to be a peak in the mid 30s, and they start to decline. And this pattern holds for whether you have intellectual disability or not. So this suggests there's something's going on here, right? And some people have talked about the accelerated aging you see in Down syndrome. Um, is that happening also in autism? We don't know at this point. What we do know is that autistic people in general have a lower life expectancy than their neurotypical peers. There was obviously a high-profile paper that was published in 2019 by the Scandinavian team using the Scandinavian Health Registry, and the study reported and often shared outcome that autistic people on average have about 16 years shorter life expectancy than neurotypical peer. I think this number has been often quoted, and I think recently there's been some attempt to try to clarify that. I think that number is for various reasons, from design to population of the study, the use for the study, cannot really be generalized, right? And there are other to other populations, and there are other issues too with the study. Um, but there's a more recent study in 2024 from the UK, and what they seeing basically, similar age range, right? 5 to 16 years, 15 years. Actually, what they saw in the UK study is that a woman with intellectual disability seemed to have the shortest life expectancy by approximately 15 years compared to their neurotypical peer. Now, what about age-related disorders? What seems to be emerging now is an appreciation that older age autism presents some unique challenges, right? In addition to the high risk for NCDs in general, we're also starting the mid 2010s seeing a report about the high rates of Parkinsonism in adults with autism, and this is consistent with the report by Lisa Krohn and Kaiser Permanente again, as well as a report study by Hilde Gerte et al. In Amsterdam, in Netherlands, that also shows report a increase in Parkinsonism. And then our colleagues at Drexel, Lindsay Shea, Giacomo Vivanti, reported in 2021, autism researcher, a first study, right, trying to look at Medicare insurance claim database to see if there's any connection between dementia and adult with autism. And surprisingly, they show that the prevalent dementia was 2.6 times higher in autistic people in a large Medicaid database. So more recently, they follow up that study with a much more robust study, larger N, that actually is a retrospective cohort. It was published in the year last year, looking at national insurance claim again, linking the Medicaid, Medicare databases. So they looked at everyone over age 30, and there were two groups that they looked at, for those with autism alone and those with autism and intellectual disability. What they saw was that autistic adults in general have a high risk for dementia, both before age 65 and after age 65, compared to neurotypical pairs. And the risk is about almost 3 times higher for early onset dementia, which is surprising, and more than 2 times higher for after age 65. There seems to be a slight higher risk for those with intellectual disability, but not terribly dramatic. And what is clear is that co-occurring conditions like depression and more recently reported diabetes and cardiovascular disease like hypertension, hyperlipidemia seem to increase risk. And this is new data that was just reported at the Alzheimer's Association International meeting last weekend. And so the implication for this study seems to be that there may be some shear mechanism involved. For example, there have been previous study of frontotemporal dementia where ASD risk genes have been implicated, like SHANK3 has been implicated for FTD. We talked about the idea that maybe we should think about improving access to care for autistic adult for this kind of conditions, and improving management of comorbid conditions like depression, diabetes, and so on and so forth, as well as management of protective factors, right? In addition to risk factors, for example, physical activity and proper nutrition and so on and so forth, health promotion related activities. Now, a slight detour, but it's related because both dementia and Parkinson's are seen as something that occurs later on in life, typically after age of 60. But there was a report, I guess, about a month ago that in JAMA Neurology that shows that the risk of Parkinson's disease seems to be elevated in adults with ASD. And this data set is more compelling. It's a prospective cohort from Swedish National Registers. So about 2.5 million people with about 50,000 autistic people was followed over time, and the age from 20 and above. And what they show is that autistic adults have 4 times higher risk for Parkinson's disease than their neurotypical peers. More importantly, what they found is that all the diagnoses were made before age 50, suggests there's some kind of early onset. So my understanding that the average age onset Parkinson's is around 60 and above. So there seemed to be a pattern of early onset. And then there's also seemed to be suggestion, this is also found in neurotypical population as well, that depression and the depressant youth seem to increase risk. In this case, seem to double the risk for autistic people. So the implications, there's speculations about shared pathway, for example, dopaminergic pathway, are both involved in both conditions, and of course there are a lot of talks about monitoring. How do we enhance monitoring and clinical awareness of the condition, especially in older autistic adults? But going back to dementia, as Steve alluded to, this past weekend, I had the opportunity to spend to be in Toronto at the Alzheimer's Association International Conference. There is a special focus research session, which is their usual session about emerging topics that are of maybe of general interest to the dementia research community. And there was this, I went to mainly to participate in this session, which really came out of a workshop that we co-hosted with Alzheimer's Association last year to explore the overlap between Alzheimer, dementia, ADRD, and autism. And it was a very exciting, session for me. It's the first time that this topic has been really fully explored in the AIC, and we had presentation from both Alzheimer researchers or dementia researchers, as well as autism researchers. For example, Lindsay Shea was there sharing, as well as Blair Braden from Arizona were giving presentation. Greg Wallace as well. So it was an inspiring session because I think data were shared that really showed that there seemed to be increasing recognition of a connection between increased Alzheimer's risk and autism. And and another big news from the Alzheimer Association International Conference is actually, you might have seen this in the news the past couple of days, is the publication of the results from the U.S. Pointer study. This is a large randomized clinical trial of lifestyle interventions, right? Multimodal lifestyle intervention. So what it was is a data set about over 2,000 adults aged between 60 and 79 at elevated risk of cognitive decline. And this is larger. And there was a study done in Finland about a decade ago. It's similar kind of lifestyle, multimodal lifestyle, multi-domain lifestyle intervention. But this is about twice as large and much more diverse in population, right? And there's two groups, one that was given structured support, other one is more of a self-guided group, and that serve both as a control as well. And the targets for the intervention are increased physical activity, improving nutrition, cognitive and social challenges, as well as health monitoring. And they did multi-domain tracking for over a 2-year period. And what they found is really impressive, right? That there's significant improvement in cognition, specific executive function, although not episodic memory, about 0.07 standard deviation per year. I think that translates to about 1 to 2 years, right? And in structured program, yield more gain, even though self-guided also delivers some kind of modest benefit. So that might be more appropriate, for example, for low resource community. Those with lower baseline possibly benefit most. This is a sub-analysis they did. And then the gain was reported regardless of sex, ethnicity, genetic risk for both with, for example, with ApoE4 benefit from this intervention, as well as those without, and as well as heart health status. And so the implications seem to be that there's community access to this kind of healthy brain health motion program will be beneficial, right, in preventing and potentially delaying the disease, dementia in in all people. So the thinking obviously turned to, for autistic people, are there opportunity for health benefit across level of support needs, something that we're actively thinking about. And then the last piece I just want to share with you before we go into some discussion is something that we've been doing recently, right? So, as you know, we've been really thinking a lot about how to identify dementia or cognitive decline in older autistic adults is a very challenging task, as you can imagine. But in the meantime, we're thinking about, how do we provide care, right? How do we deliver better care for older autistic adult with this kind of challenges? There is a CMS program that is called Guide that's being implemented and tested in the community setting since 2024. And so about over 300 organizations involved, large and small. Some are large hospitals, some are, care facilities and so on. And the whole idea is to see, to collect data so that we can finalize this model. And CMS is interested in supporting this, going forward for people with dementia and their caregivers. So what we're doing right now is that we are working with McLean Hospital in Boston, geriatric psychiatry department. They're one of the sites that's implementing the guide model, and what we are working with them to do is trying to adapt this model for older autistic adults with dementia. And I think the goal here is that the treatment unit for this model is the autistic person as well as the caregiver, right? And the goal is really try to keep both the patient and the caregiver in community setting, community living as long as possible. So we think that there may be real opportunities to create something that could be helpful for older autistic adults with dementia and other challenges going forward. We know that Special Olympics, for example, has funded a similar project for the intellectual disability community as well. And and then the last thing is that we've been thinking, looking at this model, obviously it's really focusing on just addressing the challenges of living with a autistic adult with dementia. And so things like communication, behavior, and so on and so forth. And some of this is reminiscent of what we're seeing in younger autistic individual with higher support need. So the thinking is that, is there also an opportunity to adopt something like the GA model for use for those with profound autism, but maybe younger? So the idea is to provide them with the kind of support that will be helpful, so that it can be included in community life going forward. Anyway, so I know there's a lot of bits and pieces here, and I think as I shared with Steve when I was talking about this presentation, is there's unfortunately more question than answer at this point. So there's a lot of blue sky here than rather than solid data. But I hope that you are able to I hope I'm able to share, impress upon you um, uh, in the past 10, 15 minutes or so is really that, obviously we know that nature and nurture are always interacting, determine well-being and quality of life throughout life. And nurture, fortunately, I feel like is something that are amenable to intervention. And I think also if you take a step back, to understand early aging autism is going to take time, but I feel like there's something that we can do now as we're looking for those answers to improve the quality of life and well-being of older autistic adults at this point. And I'm looking forward to exploring with you and others in terms of how maybe we can be able to do that. And then last, I just want to put up a set of questions that we're thinking about, and as a point of discussion for us. And some of the question is, how does aging impact autism and vice versa? Meaning, what how does aging affect autism presentation, symptoms, and so on and so forth, and how does autism affect the aging process in general? And when you look at things like autism dementia, what are the common denominators? There's certainly uh, suggestion that maybe pathways, for example, or there could be genes. And what does that really mean for the shared biology? Tell us about the differentiation that we have historically made between neurodevelopmental and neurodegenerative disorders and diseases. Thinking about this a little bit, you know, we we often talk about autism risk gene, right? But there's really no autism risk gene per se. I mean, there are genes that are important for, brain development, brain maintenance, right? And I think it's not unreasonable to think that because of parsimonious nature of nature, that that the gene is doing something early in life, there may be a different role for that gene later in life as well, and that the variation, the variance in those genes may have consequences later on in life. So, thinking about neurodevelopmental, neurodegenerative conditions in a more fluid manner, may encourage more insight and more research. And how could a better understanding of these connections from autism intervention services and healthcare across the lifespan? I gave you an example of the guide models of thinking about, how do we, plan, right, or think about model of care for older autistic people across the lifespan, across the level of support needs, and how can we better support autistic people with dementia and the caregivers now, right? So the idea of new inclusive care as in the guide model is something that we're actively pursuing. We recently hosted an implementation science meeting at UNC, and as part of that exercise, we kind of looked at all the major centers in the U.S., really looking for adult medicine centers that provide significant accommodation for neurodivergent populations, and there really isn't many, right? The only one that we found was there's a new inclusive cancer care unit at MD Anderson. So I think that speaks volume in terms of how autism is invisible to adult medicine, and that um, because the paucity of data and best practices, it feels like almost anything that we do now as a community will provide meaningful value to autistic people and their family going forward. So let me stop here. I know I kind of rushed through this, but let me stop here. And I want this to be more of a conversation anyway than just me talking. Back to you, Steve.
Yeah, sure. I don't know. Did you want to? These discussion points are great, so we might want to keep them up. I don't know if people know, but on the new Zoom, you have two tabs at the top of your screen though, where you can like go. Well, we closed it anyway. You can actually close. You can go between just the meeting or the slides. So
Oh, okay. Sorry. Do you want
oh
to put
no,
it
no,
back
it's
up?
fine. It's like I was going to suggest that. But if you guys want to, feel free to turn your cameras on. If you have a question for Andy or an answer for Andy or discussion point, feel free to raise your hand in the reaction button, and we can get your comments in and questions. Can I start us off with one? I have like four to ask you, but I don't want to dominate. So
Sure.
I'll ask one and see. I see Paul Carbone's on. Paul always has questions too, so he's going to ask some questions, I'm sure. Um, my first question is, okay, so if you think about the aging cohort that's being studied right now as older adults with autism, there definitely one could argue strongly there's a cohort effect that moves with them, meaning the diagnostic criteria then were much different, the presentation might be different, the symptom load might be different. So, given the heterogeneity that exists in autism, I'm wondering if those risk numbers and percentages that you're getting will hold true with the heterogeneity, with the expanded diagnostic criteria. So I want to get your thoughts about that first. So,
Yeah, I think those numbers are very preliminary, right? And like you said, it doesn't really fully account for the heterogeneity that we know that exists in the community. So I would expect those numbers to change and evolve as we learn more. Maybe even for, certain subgroups, right? The idea, as you know, recently there's a publication on the subtypes now. People are starting to, you know, the first question I had is that, are there any relations between that and susceptibility to NCDs and other conditions, for example, right? So yeah, I suspect those numbers would change over time.
Yeah, because with all the advances also assuming on the genetic front, I'm curious about, with the more significant symptom presentations of that cohort, if there's other genetic loadings that might place someone to make them more vulnerable for those numbers shock the heck out of me though. I mean, those are huge percentages, both for Alzheimer's and Parkinson's. I had no
Mhm.
idea. So maybe those numbers will shift with heterogeneity. Again,
Yeah,
if you have a question or want to answer, we're going to put those discussion points up in a few seconds again so we can answer all of Andy's questions for him. We have a group of very smart people here, so I'm sure we can give you some insights. Um, but as I also wait for other people to raise their hand, I'll ask my next question. Why do you oh go ahead, Paul. Yeah, Paul, you go first.
Sorry, I'm so old I can't figure out how to raise my hand anymore, so I'll do it manually. I'm a primary care provider, and I've worked for a long time in a primary care clinic that treats folks with autism and other developmental disabilities. And this is a great research topic that really needs to be fully explored. So thanks for sort of embarking on this path. I sort of look at this as a primary care provider, and I remember there was a Lancet did this big paper. It was a commission paper on dementia a long time ago that I read. As a pediatrician, I don't read about dementia very much, but it really emphasized one of the points in the paper that I remember is that some dementia is preventable. Like if you control blood pressure better, if you address hearing loss, exercise, social connection, all of those things. And just in the pediatric world, I study how people with autism get their primary care, and we know that their primary care is not as good or as high quality as people without autism. So pediatric patients don't get their blood pressure checked as often as people without autism. They don't. So I assume that really almost gets worse into adulthood, not better. And so I wonder if there's we're talking about, genetic susceptibility to autism, and that makes sense, or to dementia in people with autism, which makes sense to me. But I wonder if there's a separate sort of research question about just the things that we really can control in terms of getting better primary care and addressing hearing and blood pressure and all those things that people with autism really need, and how that would affect. So it'd be interesting to look at a cohort of autism and find out who gets better primary care and their rates of dementia, prevalence of dementia long term. But just
totally.
wanted your thoughts on that.
Yeah, I totally agree, Paul. I mean, I think, this is part of my point, right? I mean, I think to understand the biological differences and how that could inform care will take a minute, right? But in the meantime, I think there is something that we can do, and these are these, social determinants that are amenable to modification and accommodations. Uh, so, one of the things that we know that improve pediatric care for autistic kids is awareness, right? The tools, education, and experience, and so on and so forth. But that doesn't exist, right, in adult medicine at this point for most fields. I think more important is what you also pointed out is the health promotion aspect of it, right? I'm not, I hear a lot about problems about obesity, about lack of physical activity and lack of social engagement and intellectual challenges. These are all things that are identified as risk factor, right, for dementia and ill health in general, right? I mean, talk about NCDs, ill health in general. There's no established health promotion program for autistic people, especially those with higher support needs, right? So if something like was having something like that make a major difference in the outcome, I would think so, right? I think that's where the near-term opportunities are for us as a community.
Thank you, Claire, for posting that paper. This is what I love about this community. It's like you guys mentioned, Paul, you mentioned the article, Claire posted in the chat. and has a great graphic for all the different updated risk factors that are preventable and for dementia. And thank you, Diana Robbins, for the paper from Avanti that Andy also mentioned. You posted
Yeah.
that as well. So, um, okay, so building on what you and Paul were just talking about, I realize this is just pure speculation, but what do you think, aside from whether it be genetic or whether it be these preventable factors, why this such an increased vulnerability in this population? It's a big question, but please answer it.
Yeah, I mean, I think my guess is good as anybody else's, right? I mean, I think, some have been proposed by the study authors for the Parkinson's study, for example, because, for example, both Parkinson's and autism involve dopaminergic system. You can imagine how a variation, in that system could lead to, different presentations. But I do think a big part of it is lifestyle, right? And I just I keep thinking about uh, the life expectancy issue. I know there's still some controversy around it, but what is clear is that on average, autistic adults have shorter life expectancy. And maybe some of that is due to biology, but I think a lot of it is due to, the social support system that we have, right? And the risk factor that we're not managing at this point for them. Um, anyway,
Yeah, no, I think it's great. Again, we don't have the answer, otherwise we would have written a paper about it. It's like I just came back from a workshop where Dan Geschwin, Genesis was there, and others, and it's like I just trying to to somehow uh, have what they reported there on the genetics. How does that fit with this? In terms of these common pathways and such. And that's the part I'm not getting. So the only another really strong answer would be the modifiable factors. Dana, go ahead.
Thanks. This is a great discussion. I was just wondering if anybody on this call is working on strategies to assess cognitive decline in autistic adults who are not able to do any of the standardized dementia testing. We've got some very, very preliminary pilot ideas that we're starting to float. Giacomo Vivanti is leading this, and it would be great to partner with other people. My original training background is as a clinical neuropsychologist, and so I'm quite aware that all of the ways that we can measure possible cognitive decline or the early stages of dementia, things like dementia rating scales or any task related things, are not necessarily appropriate for this population. We are just wondering if we're the only ones starting to embark on this, or if there are other people out there. And Andy, of course, if Autism Speaks is interested in this, we are looking for funding. But
we are totally interested in it.
okay, well, I mean, I can talk to you offline about what
Yeah.
we've started to put together. We have some pretty exciting ideas.
Yeah, I mean, I'll give you an example, right? I mean, this is having tools, right, for this is essential, I think, at this point. One of the things that we've been thinking about longitudinal cohort study, right, and especially identifying older autistic adults. I think there's a couple of challenges there. Is that how do you identify someone who had not been previously diagnosed, right, in older age? So given the Parkinson recent results, right? So we've been in touch with Michael J. Fox, and they have a large registry. And what we learned is that all the members in the registry have not been screened for developmental history. So it's interesting, right? So we're working with Vanessa Ball and Kathy to fill the questionnaire, with that registry. So that's one example of an approach I think that we can take to some of these populations to see if there are any clues, right, that we can glean from.
Great,
I,
thanks.
I, I really do think that's a central challenge, right? How do you identify autistic people have not been previously diagnosed?
Just in
Right?
general speaks to our lack of knowledge in this area, right? So, and lack of no one's studied this much. So, Gregory, do you have a question?
I don't. I have a comment. So, just to Diana's question, there are established, again, it's proxy ratings, but they're established, I'm sure you and Giacomo know about them, for people with intellectual disability. There's like the D-SCLD, like the dementia scale, blah, blah, blah. And then there's the NTG EDSD. Again, I don't mean to spit out acronyms. I just don't remember what they all stand for, which is the National Task Group, maybe. But task-based, if that's really what you're focused on, Diana? Or did
So
I
we're not
first?
in, so not task-based, but more direct measurement. So we're actually proposing to pair informant report with some things that we could measure directly. Um, Obviously they can't be task-based, because if you could ask a person to remember 3 words or draw a circle or whatever you wanted to have them do, then we could just use the things that already exist. So we are exploring novel ways to get direct measurement to combine with informant report. And we're partnering with an agency that has residential programs. So the informants can't always be like a family member who's known the person, for 40 years
Right.
or 80 years or however many years. Um, Sometimes they have to be staff who regularly interact, but they can still inform on activities of daily living or other aspects. But that kind of informant base doesn't seem like it will really capture the whole picture for us, and that's why we're looking to explore what can be combined.
That makes sense. I would just also point out that when you use, I think someone's got a critique of the D-squid, for example, in the chat. I do think it has limitations, but I also think the key issue here for all of these is the fact that when you're dealing with someone who already has a pre-existing cognitive impairment, you have to have a historical context if you're not prospectively following them, which is really what it relies on. And it's not just cognition, obviously, it's also daily living skills and other things, which goes to what you were showing, Andy, from Marshall Malick's group. Yeah, I mean, I was going to say something else, but I've lost it. But yeah, it's a huge challenge for sure in trying to get those performance-based or direct assessment.
There's a couple other interesting and good comments in chat. If you guys want to look at those too. Um, do you guys have you seen gender differences in this? Which is hard to see, obviously, in the original cohort that's being followed. It's almost all male, I would imagine. But I'm just curious on the Parkinson's, Alzheimer's risk. Was there a gender breakdown at all, or sex breakdown?
There was. Whoops, there was. Um, Let me dig it up.
I assume males were more at risk. Is that
Yeah,
um,
um, no, not in dementia study in terms of differences. No, I don't think so.
oh, okay? Interesting. Um, do you know? I have one more question. Sylvie, I saw. Did you want to say out loud your comment about Diana, Sylvie? It's frozen on my screen.
I'm sorry.
Oh, sorry. Sylvie had posted into chat, and her camera's still on, so I didn't know if Sylvie, if you wanted to mention that out loud or not. So it's dangerous, Andy, in this group if you turn your camera on. I'm talking to all of you. Um, do you know? Okay, here's another question. Were they at this conference, or just in general? Did they talk about again the mechanism of protection that the exercise and the change may work? Like, why is that so protective at a really basic level?
I didn't get that level of detail, but I think I mean maybe Greg and others who were at the conference can share more light on that. But I think the general thinking about exercise and physical activity is that because they really address cross-cutting risk factor for general health, right? And so, for example, we know that from the Drexel, recent analysis from Drexel study, the hyperlipidemia is a risk factor. Hypertension, increased risk. So, being able to support better cardiovascular health, metabolic health through this intervention will reasonably translate to better management of these risks for autistic people. So, but I didn't. Obviously, I'm not. I didn't catch the mechanistic aspects of the.
Yeah. Yeah, I mean, it just speaks to, again, the challenges in this population, right? Because it's hard enough to get, neurotypical adults out there and exercising and avoid these risk factors, given the challenges and or proclivities of autistic people, especially as they get older. You can see where that just is going to be more and more difficult, and speaks to, like, we need to be more proactive, like you said, and being able to provide programs that address these, right?
Yeah, I think what is striking for me in that the lifestyle intervention study is that kind of a structure. So health promotion programs seem to have the greatest impact, and I feel like for our community, that kind of structure is almost essential, whether regardless of level of support need that you have. Um, I think even though I think the self-guided model in low resource community probably would be more feasible, but I think it speaks to an opportunity to start thinking about preventive care, right, for autistic adults, which is not really a discipline at the moment. So
Yeah. Yeah, having worked in both the Alzheimer's, Parkinson's field and autism, I can appreciate, what Diana was talking about and others about the challenges of accurately measuring any type of decline or anything you might see would be enormous, coming out the right tools to figure that part out, right?
yeah.
Kate Loveland, I saw you had put something in chat. I don't know if you're willing to mention. I know you also see a lot of adults at your center down there. Are you seeing a lot of the adults or suspect them of having a type of dementia, Parkinson's, Alzheimer's, anything? I don't even know if you're still on the call, but I was just curious if you're able to speak to it at all. Or anyone on this call. There's not a lot of us that see adults, quite honestly. There's not a centers that see a lot of adults. For those of you who do you see a lot of this dementia and Alzheimer's? It's a 4 times greater risk. You'd think we would. I'm just curious. Elizabeth, you're shaking your head, and I see you like Elizabeth at Drexel. Have you? Sorry, you put your camera on. Do you see this too, or?
So we don't have a clinic actively seeing adults. I'm shaking my head because of the conversations Diana mentioned with our community partner, where we're embarking in both clinical and research ideas around this. And they've shared anecdotally, yes. But I came off camera, actually, it's a good segue, because Andy, what you mentioned about the Parkinsonian tool, like essentially trying to look at a database and say, okay, what was the developmental history or who's in this group from a phenotyping perspective? That's what we're really grappling with this enormous outpatient center that has all these residential homes and wonderful services, many of whom these adults, their caregivers, are not alive or around to give us any sort of history. So thinking, how are we going back to records, et cetera, is a conversation we've been having a lot with this outpatient center. I wonder, you mentioned with Vanessa and Kathy, is that a potential near future tool? Or because I think we're all kind of making up, those of us who are trying to do this work are figuring it out as we go, but having something standardized would be incredible. So I imagine it's not going to go live soon, but any more info there would be awesome.
Yeah. Yeah. Hopefully we'll have some preliminary insight later this fall at this point. So
Awesome. Thank you.
and we're analyzing data now.
That's great.
Gemma, did you have a question or comment too, or? People come off camera, I'm like, oh, they must want to say something. So.
Yeah, I'll just so I run a program for adults with autism and significant intellectual disability, so profound autism generally, although a couple of exceptions. So this is a small cohort of 15 people. But in this small cohort of 15 people, we have one adult who died in March, secondary to onset of dementia at age 53. And we have a second adult who was diagnosed in his 30s with Parkinsonian symptoms. And he is now 62 and still with us. So anyway, those are my two sort of in-depth clinical examples. And these are two adults who have lived here in this program. I work at Teach in North Carolina. So these are adults who have lived at this program for, in one case, 30 years, and the other case, 23. So we have a lot of background information about them and their history because they've lived here most of their lives. And I'm also the one who made the comment about the D-squid. And the problem with the D-squid is that the floor is so low that if you have someone who has so few skills to begin with, you cannot show decline on a measure that's asking for a change in skills. Although we could observe decline, we could not reflect that on the D-squid. So I just wanted to elaborate on that comment and then explain that I have seen this in a relatively small cohort.
Thank you. Yeah, and Celine can speak to this too. We know in the Vineland research that we've done, like it's really hard to use that as a measure of any type of change, even in the dementia world, just because autistic individuals have a much different profile that messes with your basal scores. I know because I'm more spotty ahead of that, and they can do skills that other people would have scored off because of their floor. So it's a hard area. I know there are groups working on a better way to measure adaptive skills in profound autism and other types, and that might be applicable to here as well. So, yeah.
So I have a question, Steve. For people on the call right now. So when you run into a let's say adolescent patient right now with the cancer or metabolic disorder or heart disease, who do you refer them to?
I mean, I can only speak to where I've been, the different places. What we find is, most of our centers that I've worked in are autism specialists in terms of diagnostic services and treatment services. But then when you start to overlap into other medical areas that are outside the general specialty of autism, we usually try, first of all, to find a medical specialist that knows autism or at least knows how to treat in the context of autism. That's often not the case, though. You just can't find them. So instead, we refer them to the best people out there and then offer up our services as best as possible on a consultative level to say, and even have a discussion with them ahead of time, or at least talk to, because oftentimes the autism context doesn't make a difference, but oftentimes it does in many different ways. So I don't know, other people think differently, or feel free to mention it. Paul thinks differently?
No, in the clinic that I'm at, where we just take care of folks and we provide their primary care, we refer to the same specialists that we would if they didn't have autism. Oftentimes we're working with them closely to kind of provide that bridge to, like, how do we adapt whatever care you're recommending to this individual and their particular strengths and challenges. So there's a lot of co-management, and that requires a primary care provider who's just really invested in autism, which is, I think, what our clinic sort of value adds for folks. But there's not many of these clinics in the country. And then I think what you're kind of getting at, Andy, is like, what happens when the pediatric subspecialist sort of like, okay, like you've hit the age where I'm not going to follow you anymore. This happens a lot in GI, for example, where you have kids with chronic constipation or a bunch of specialties. And that just requires a lot of advocacy from the medical home, from the primary care provider to find an adult specialist. And, again, in our clinic, where all we do is care for people with developmental disabilities, we kind of know the adult specialists in the community we can transition kids who have epilepsy to an adult neurologist, for example. So it's just a matter of like knowing your community well and knowing who the people who are have an interest in this area and expertise.
Thank you for that. I know this is one of the challenges that we discussed at the UNC meeting, for example, with Gemma. I think what we learn is that many adult autistic people don't self-identify when they go to a clinician, right? Because they usually get turned down for services. So many of them do stay with their pediatrician even though they're adults. So the thinking about, referring to specialists as the need arise, becomes feel like it's more complicated. So
Yeah, and for like depending on if it's someone with higher support needs and or pediatrics, our ABA folks have actually done stuff like we had a mock MRI machine where we would do behavioral work to try to get them, or phlebotomy, same thing, So, but again, it's like I think what I'm taking away the most from this talk was just this lack of attention that's needed
yeah.
into this area and being able to treat this area. It's huge. And again, the tsunami is moving forward, right? All these kids are getting diagnosed and they're going to become adults. And then we're going to have to like somehow provide good care, which is the best segue to, we have 2 minutes left. So first of all, thank you so much, Andy, for your thought-provoking and very, very interesting discussion, things that I don't think about as much as I should. But it also leads to so next month, it's going to be really interesting. We have Dr. Amy Essler, who's part of the CDC task force for prevalence rates. She's done this for us every time they've been published. She's going to come and give us not only the forest, but some of the trees with regard to the prevalence numbers, which are super interesting and humbling in some ways, but also their thoughts about what they've looked at more in depth and the nuances associated with the prevalence numbers. She's going to talk for the first half. And I've really tried in these idea talks to avoid political stuff as much as I can, just because I don't think that's our role. Although it's hard to avoid anything political these days, as we've talked about already on the listserv. We've had many patients cancel because of the registry, in terms of their appointments. There's all kinds of stuff going on. Obviously with RFK and with we're gonna have a cure, or whatever the cause, and I think he's pushed it back to next year. But the next interesting talk after Amy is Helen Tager Flussberg has agreed to come on to talk. She's heading up and has formed the Coalition of Autism Scientists, who wrote the letter that basically pushed back on a lot of what's happening. And if you've ever met Helen, if you haven't, you want to come talk. You want to come listen to this talk. She's a force of nature herself, and is brilliant. So I can't wait to hear what she has to say about many of these topics and just the thoughts that are going on that affect our field so deeply, and my patients that I see in such a huge way. So there's a cold front moving through, so we have storms, and it's going to finally cool off in my part of the country here. So I hope it does yours as well. But I have a nice last day of July and a nice August, and we'll see you guys in a month. Thank you again, Andy.
Thank you so much, everybody. Take care.